anything you can name, we see them. Okay, so welcome. So we'll get started. So a lot of times we always ask ourselves, what is pain? Why do we have pain? Is it a good thing? Is it a bad thing? It hurts, so it's like we always think, well, it's kind of bad. It's not a good thing to have, but actually it does serve a purpose. So believe it or not, pain is actually one of the oldest medical problem documented in history. Pain is defined as an unpleasant sensory or emotional experience that we all have experienced since we are born. Pain has always been our teacher. It teaches us how to avoid sharps, avoid burn. We learn about pain as we were born. Toddler or infant, they crawl, they bump their head into a rail, it hurts, so it teaches us to, okay, avoid doing that again. So it's a signal to tell us that there is some kind of potential injury or ongoing injury happening. So pain is indeed a good thing. So and for a short period of time, we found that opioid is a very effective way of treating pain, but it's very effective in shutting down pain signaling pathway. But we found out it's not really a long-term solution for chronic pain, because now that we know we have the opioid epidemic, we know that it actually creates problem. Yes, it does help with pain, but also creates problem for people suffering from chronic pain. For example, we run into problems like addiction, we run into problems such as dependence, tolerance, and people overuse it, overdose it, can put you at risk of respiratory depression, where people stop breathing and they can die from it. So we'll start a little bit off with a little history of pain medicine. How does it evolve? How do we get to where we are today? So in the ancient Greeks, there's a very famous philosopher, scientist named Aristotle. He believed that pain actually comes from evil spirits entering the injured site into the body, and therefore you experience pain. Hippocrates, you probably heard of this name at some point in life. He's by far the oldest or the earliest documented physician in ancient Greek, and he believed that pain actually came from an imbalance of vital fluid in the body. There have been so many ways that we have attempted to, that may over the past 500 years to figure out how can we control pain without medication. You can see in a painting on the right, it's a painting from the 13th century showing a surgeon operating on a patient's right arm, and he tell the assistant, hey, focus, do a fixed gaze on the patient. That way help to divert his attention and therefore alleviate pain. Of course, I don't think that's going to work at this point anymore. So this is another a picture of showing ancient Egyptian doctor figuring out that, hey, maybe we can press on the carotid artery, which is the artery in the neck, and therefore there's no blood flowing to the brain, and so the patient become unconscious, and therefore it helps to alleviate pain. And now we know that if you do that, yes, the patient will, or the person will lose consciousness, but the problem is you're going to develop a stroke, you don't have blood flowing to the brain, so it's going to cause more problems. This is a cartoon figure or painting that actually showing an ancient Egyptian doctor trying to treat a patient with swollen gums as well as toothache. You can see the patient with a little funnel in the mouth, and basically the ancient Egyptian doctor is trying to pour some of the paste. That what they do is they will grind a dead mice and mix it with other ingredients, pour it in the mouth to treat toothache. Sometimes if the toothache is very severe, they even put a dead mouse into the mouth for treatment. Of course, we know that that's not going to work as well. In the 17th century, this is a painting from depicting the 17th century. I would think a minority of Europeans, or a very small group of Europeans, they actually believe that by ingesting human remains can actually help treat some of the conditions or diseases, or even treat pain. Actually, this has we have a branch of medicine of what we call homeopathy. It's kind of like that nowadays, where it follows the concept of what we call like cures like. For example, in the 17th century, a minority of European, that's what they said, was basically if you have a headache, they would grind the human skull into powder and ingest it, and believing that will help to cure a headache. Of course, again, we know that that's not possible, that's not true. Now, here's an interesting figure showing that in the 18th century, snake oil become something very popular, that they believe that it would relieve pain. And you can see in the bottom, greatest pain remedy on earth, wonders famous rattlesnake oil, $1 a bottle for only 50 cents. So actually it has quite a bit of history, very popular in China. Even nowadays, they still use snake oil for treatment of pain. And of course, a lot of people initially believe, hey, you know, this is probably just fraudulent. It's not true. But there was quite a bit of research that were conducted in the 1980s and looking into how snake oil, is there any property that could potentially help with pain? Actually, they found that the potential source of snake oil in alleviating pain is actually there's a very rich source of omega-3 in there. And they later found that omega-3 actually helps to reduce inflammation, therefore helping to alleviate chronic arthritic pain. On the picture, a picture on the left, a very famous drawing. Basically, it's kind of like an auditorium showing that a lot of physicians looking at a patient sitting in the chair. You can see the patient has already completely lost consciousness. And you can see just left side to the patient, there's a guy, his name is William Morton. In 1846, he performed a demonstration where he would, where he's holding a little glass globe, and it contains ether in there. And he demonstrated how using ether can put the patient to sleep, and therefore the patient would not be able to undergo surgery without experiencing pain. And on the right side, you can also see a picture of chloroform, which also came into usage for helping to alleviate pain in the a little bit after what happened using ether, which is about in the 1853. In the 1850s, where Queen Victoria actually, she had chloroform that was performed by a physician named John Snow, and she was able to give birth without having any pain. Now, of course, chloroform we don't use this anymore as a part of alleviating pain or anesthesia, because the problem with chloroform is that people actually can die from it because it does induce cardiac arrhythmia, meaning arrhythmia of the heart. Now, by the 1900s, that's when the morphine, the heroin really came to use as pain medication. And indeed, opium has a very long history. The cultivation of opium was dated as early as the 3400 BCs. Opium use dated back as early as the 1600s. You can see the picture on the right. Opium actually came from a milky sap from a flower called opium poppy, and they extract it from there. In the 1600s, it's very common that many European doctors gave their patient opium to alleviate pain, whether it's for cancer, menstruation, childbirth. But they found that the opium actually has an addictive property. So they actually try to figure out a way how to reduce that addictive property. And that's when they actually synthesize morphine from opium. Of course, hoping that it will reduce the addictive property. But unfortunately, they found that morphine just has the same addictive property. It actually ended up to be even a more well-received product because it's very pleasurable when they used it. So they thought it would reduce the addictive property, but it didn't end up doing that. This is a picture, probably most of you would have heard of the Opium War, where the British was trying to purchase the tea leaves from the Chinese. But of course, the Chinese, well, they didn't really need anything, they didn't really have anything in particular they want from the British. but they found out that, oh, they actually wanted the opium, and that's kind of how that's the opium war, where they actually trade the British trade the tea leaves for the opium, or the other way around. But this is a picture of basically showing the Chinese, how they become addicted to opium use in the past. I think it was more in the late 1800s. Then later, there's a guy named Charles Ramsay Elder Wright in 1874. So again, they were trying to reduce the addictive property by producing or synthesizing morphine from opium. So Charles Ramsay, he's trying to come up with another compound that could potentially, again, reduce the addictive property of opium. So he came up with heroin. So as you can see, Bayer, it's a pharmaceutical company in 1898. It's a German pharmaceutical company that you can see on the right side, there's a picture of an advertisement showing that, it's great to use in children for suppressing cough. They even use it for labor pain surgery, but they found out that it's actually widely abused. It actually has more addictive property than morphine and opium. So it was subsequently banned under the Heroin Act of 1924. As you can see that the CDC published some of the data, and basically in 2017, there's actually a report of 70,000 people who actually die from drug overdose, and more than half of them is actually coming from opioid itself. And this is another graph or data basically showing that there's statistically significant increase of death rate in patients using that die from overdose of medication. And the ones that are in red, they are the ones that statistically increase in death rate, including California itself. And that was between the year of 2016 to 2017. So basically, is it safe to use opioid to treat pain? So that's kind of the question where we kind of came down to. Well, it really depends. It depends on the type of pain. So in general, there's many different forms of pain, but to kind of keep it to make it simple, there's acute pain and there's chronic pain. Acute pain is when you injure yourself. You broke a bone, you burn yourself, you have a paper cut. It's something the source is very clear. Whether you broke a bone, you burn yourself, you have a skin burn, the source is very clear. They tend to respond fairly well to opioid because it's an acute form of pain. For example, trauma, surgery. We do a lot of opioid for post-operative pain, meaning after surgery. Opioid tends to work really well for pain from the incision site of the surgery. Other things, including like appendicitis, they tend to work very well. Now, however, chronic pain, on the other hand, is completely different. Chronic pain is defined as pain of whether there's a clear source or an unclear source that lasts more than at least 6 months. The source of the pain could be clear, but it could also be ambiguous. You might not really know, maybe the source of the pain is very unclear. They tend not to respond to opioid very well. Nobody really knows why. The data didn't really shows that the opioid works very well for chronic pain, although it works really well for acute pain. So why is it important to manage chronic pain? Many of us, many people in our population are suffering with chronic pain. So we could continue to live with chronic pain, but why is it so important to manage? And the reason is, when we look at the pain cycle, it basically runs in a cycle. So if we start at the 12 o'clock direction, it will show a person currently in chronic pain. They are always having pain. So when we're gonna go clockwise. The patient will become less active because every movement, a little bit of movement, it's gonna hurt them. They're gonna lose their muscle mass. They're gonna, because they're not moving as much, the joint, they're gonna lose the function of their joint, mobility of their joint, flexibility of their joints. They're gonna lose the muscle mass, so they become weaker. They started to lose energy. They feel tired all the time because they're not active anymore. They can't do exercise because they're always in pain. And because they can't do things, they become very, you can become very stressful, you can be anxious, you can get angry and frustrated because you want to work, you want to enjoy life, you want to go, enjoy the hobbies that you want to do, but you can't do them because you're always hurting. Then the patient can start to develop some of the negative thoughts. They worry about their future, always thinking about pain in their life, and that can develop into depression, mood swings. And believe it or not, actually 60% of chronic pain patients has depression. So it's not uncommon. So, and then they run into problem with works. They can, because they have pain, they can't do their work. They can't go to work because it hurts them, and they lose their job. And then money comes into a problem. They can't make a living. They always get frustrated, angry, and that can also harm their relationship problem. And guess what? And that leads back to creating even more worsening of the chronic pain. So it becomes a pain cycle. That's why it's important to manage chronic pain appropriately. Some of the common causes of chronic pain, probably common causes of the most common cause of chronic, the most common chronic pain that we see in our clinic, probably I would have to say number one, low back pain. Whether it's family doctor or internal medicine doctor or even pain physician like us, we see a lot of chronic pain patients due to low back pain. Other things like neck pain, thoracic back pain, you name it, anywhere that any part of the body could potentially develop into chronic pain. Chronic low back pain is one of the most common cause of people suffering with chronic pain. Some of the common causes of low back pain, like degenerative disc disease. As we age, everybody will develop at some point will undergo some type of degeneration, whether it's the joint, whether it's the disc. So they can all be potential cause of chronic low back pain or neck pain. Spinal stenosis is another very common cause of low back and neck pain. Basically, stenosis means narrowing. So it could be coming from a disc herniation, could be coming from a joint arthritis. That form bone spurs that can all lead to narrowing of the spinal canal, and that can lead to symptoms of pain in the low back radiating down the legs. Radiculopathy is just basically referring to an impinged nerve, like people always talk about sciatica. So that's what radiculopathy means. Facet arthropathy, just like any joints in the body, we have knees, we have hips, we have shoulder, elbow joints that allow us to do, that allow us to flex our arms, flex our elbows, extend our elbow, move our shoulders. Same thing in the low back and the neck. There's always joints that allow us to bend forward, bend backward, turn our neck when we drive, things like that. So they can become arthritic too as we age. Sacroiliitis is another very common cause of low back pain. It's basically the lowest joint in the sacral area. Coccydynia is a tailbone pain, basically referring to a lot of time we see patients, they might have a fall injury, they land on their butt, and then it kind of fracture the tailbone, and that can lead to chronic pain. Peripheral neuropathy is actually something fairly common, and most of the time patient will complain of, they will have pins and needle sensation in their feet. They might have burning sensation. They might have numbness, tingling, or sometimes they'll feel like, I feel like I'm walking on marbles. They will have all these weird different sensations they can get on their feet as well as their hands. And that's because of peripheral neuropathy. Some of the common causes like diabetes, vitamin deficiency. Some people, cancer patient after chemotherapy can develop that. Alcohol is another potential cause. And actually the most common is idiopathic. Nobody really knows. It's just part of, again, aging process that things degenerate over time. Chronic abdominal pain and pelvic pain, they're less common in my clinic, but I do see them once in a while. Some of the potential causes like cancer, chronic pancreatitis, endometriosis, things like that. Complex regional pain syndrome, very debilitating pain disorder, usually involving a limb, whether it's the arm or the leg. Myofascial pain syndrome is very common. I would say almost everybody at some point in their life will have some form of myofascial pain syndrome. Basically, in short, it's kind of like muscle pain. Compression fracture, this is something more, we see it more in elderly patients because as we get older, as we age, we undergo hormonal changes, we have menopause, our bone density will decrease, and therefore we develop something called osteopenia or osteoporosis. And a lot of time that can just spontaneously result into a compression fracture in the spine. Of course, there are people after a motor vehicle accident, after a fall injury, can also develop compression fracture. Other causes of chronic pain: headache, fibromyalgia, cancer pain, trigeminal neuralgia, something that we also see in the clinic once in a while. So the prevalence of chronic pain, at least 10% of the world's population is affected by a chronic condition. Every year, there's at least 1 in 10 people who develop some form of chronic pain. And the World Health Organization basically stated that osteoarthritis affect 10% of men, 18% of women aged above 60 years. Rheumatoid arthritis, about 0.3 to 1% of general population, but rheumatoid arthritis is not very common. When I have patients with rheumatoid arthritis, it can be very debilitating because it literally affects every joint in the body, and they tend to be both sides. So both shoulders, both hips, both knees, neck, low back tends to be just affecting every joint. So it's a very debilitating disease. And by far, again, low back pain affects nearly everyone at some point in time, and about 4 to 33% of the population at any given point, probably by far the most common cause of pain, of chronic pain that we see in our pain clinic. So when the patient come in to our clinic, we always do a pain assessment. We start off with the clinical history. How does the patient present it? We ask questions like, where is your pain? How long have you had it for? How would you describe it? Is there any numbness or tingling? Does it radiate to like an arm, or does it go to a leg? Is there anything that make it worse, make it better? All these questions, just based on the clinical history, a lot of time we already can come up with the diagnosis. Of course, we still do a physical exam. We look at some of the imaging study to kind of help us figure out if what we think is the diagnosis is truly the diagnosis. So it kind of help us, give us some more information to confirm that we have made the correct diagnosis. And once we make the diagnosis based on the clinical history, physical exam, imaging studies, then we come up with a customized treatment plan that best fit for our patient. And you can see on the picture on the right, the doctor is holding a radiograph, and you can see the x-ray film that the patient already has a little curvy spine. That's what we call scoliosis. And if the patient has low back pain, that could be a potential cause of the patient's chronic low back pain. So how do we measure pain? We always say pain is considered a fifth vital signs. But unfortunately, pain is very difficult to measure. It's very subjective. So we, of course, the best we can do is come up with a pain scale. You always hear, if you've been to a pain clinic or a doctor's office, they would sometimes ask you, hey, can you give me a number from a 0 to 10? What's your pain score? I'll tell you that, I would have a patient 2 weeks ago. I have a patient came in extremely uncomfortable. He is having low back pain. He has numbness and tingling down the left leg, and he is standing. He just can't sit still, and he would give me a pain score of a 6. He's sweating. He's hurting a lot, but he gave me a pain score of a 6. I'm looking at him. I'm thinking that's more like a 10. But again, it's very subjective. I would have another patient come in and sitting there and tell me, well, my neck hurts. But she would give me a pain score of a 9. But you can see that, she's fairly comfortable. She's not like breathing. She's not like having shortness of breath. She's just not sweating. she's sitting comfortably. So that's why pain is very subjective to everyone. There's no one way to measure. Of course, there are some studies that in the academia they say, oh, we'll draw some blood. We're looking at certain chemical in the body and measure the level, and therefore we can maybe objectively measure pain. But again, nothing is really standardized at this point. So getting into our treatment of chronic pain. So, there's a lot of smart people in the academia. They do a lot of research, do a lot of studies. They try to figure out what's the best way to manage chronic pain. And after so many extensive years of research, they found that the best way to treat chronic pain is through a multidisciplinary approach. What that means is that I break it up into three components. There's the non-pharmacological, there's the pharmacological, and there's the interventional component. So we'll start with the non-pharmacological. Cognitive behavioral therapy and biofeedback, they can be very helpful, especially for patients with chronic pain. Usually they were being performed by a pain psychologist. Basically, they're trying to use ways to help the patient understand the underlying process that controls the pain in the body. And therefore, by understanding their body better, that way they can reduce the pain. There are many studies that have shown that biofeedback as well as cognitive behavioral therapy has been very effective in managing chronic pain. Physical therapy, aquatic therapy are also very helpful. I love to refer patients to aquatic therapy, especially people suffering from arthritic pain. So imagine if you are having arthritis. Arthritis is basically when you are suffering from pain due to wear and tear. So you are in the joints. So the joints are now bone on bone. So the only way to strengthen those joints, of course, if you do it on land, they can be a little tough because, for example, if you have knee arthritis, you're standing, gravity is going to make your knee hurt because it's bone on bone. So aquatic therapy, basically you're floating in the water, they take the factor of gravity away, and therefore it will alleviate the pain, and therefore you can do more exercises and stretching. So that's why one of the things is I love to refer patients to aquatic therapy, and there are good studies that shows that it has been very beneficial especially for arthritic pain. Chiropractic manipulation can also be very effective to certain patient population. What they do is they try to manually realign your spine, realign the areas where they think it was out of alignment. So they try to realign it manually using their hands. Acupuncture, the evidence for acupuncture has been, we call it moderate. Some of the studies basically shows that the best thing that acupuncture can treat usually involving the neck, the low back, and maybe the knee. But again, the evidence is moderate. I usually like to tell patients, try it for a couple sessions. You can try for 3 to 5 sessions. If it works, keep going. If it doesn't, then maybe you can stop. So it's not for everybody, but if it works out, yep, it tends to be very effective. Yoga and Tai Chi are also very important. They help to train the patient, learning how to relax. Meditation is also part of yoga and Tai Chi, learning the breathing technique, and also stretching. Massage therapy are helpful, especially people suffering from more related to muscle-related pain. Weight loss has been shown to improve the function of mobility as well as reducing pain. There's many studies conducted as well. Smoking cessation, there's again plenty of studies that already show that nicotine contributes to chronic pain. And of course, last is diet modification. So going into a little bit on dietary recommendation, diet modification, you might know that there's actually food that are more pro-inflammatory versus anti-inflammatory. So one of the recommendations is to reduce cholesterol. Cholesterol has been shown in studies that actually induce pro-inflammatory cytokines to be released. Basically, in other words, cholesterol has been shown to induce inflammation. So by reducing cholesterol, that way you can reduce inflammation in the body. Some of the example, fortified milk, yogurt, any kind of fiber-rich products, soy, any kind of soy products would be very beneficial in reducing cholesterol. Weight loss and exercise, again, there's studies that specifically show that even 10% of weight loss will help to reduce pain and improve mobility. Increasing intake of long-chain omega-3 fatty acid. As you can recall earlier, there's a little history on the snake oil. So snake oil has a lot of omega-3 fatty acid, and there are research already showing, proving that omega-3 actually reduce inflammation. Oily fish, tuna, salmon are very rich in long-chain omega-3 fatty acid. If some patients don't like fish, then 1 to 2 fish oil capsules per day would be very, very helpful. And also recommend using oil that are rich in monounsaturated like olive oil. Vitamin D is also very important because there's already good evidence showing there's a very strong association between cartilage formation and vitamin D. Oily fish, egg yolks, fortified products, they can all have very high, a significant amount of vitamin D inside. So that will be these food are all very helpful. Vitamin K is also important for cartilage metabolism as well as cell proliferation and survival. So vitamin K is also recommended. Leafy vegetables, anything green and leafy vegetables are gonna be rich in vitamin K. So now that's the non-pharmacological side for treatment of chronic or management of chronic pain in general, not just back pain. Now we're going to go into the pharmacological side. So basically medication. My favorite, of course, topical agents. Why? Because if you think about most of the medication that we ingest orally, whether it's Tylenol or ibuprofen, everything that you swallow orally, it's going to go into the blood and it's going to affect every organism in the system. Topical agent, on the other hand, you put it on the skin. Yes, it gets absorbed through the skin and penetrate into the localized area. But maybe about 5 to 10% really ultimately get absorbed into the blood. So the effect on the body is very mild or minimal, if not. So that's why topical agents, I like to prescribe patient with lidocaine patches, lidocaine cream, Voltaren gel. All these are these are all could be effective way of controlling chronic pain. NSAID is something that we, and acetaminophen is something that we have over the counter available to purchase for pain relief. NSAIDs such as ibuprofen, Aleve, naproxen, Motrin, you name it. They all fall in the class of non-steroidal anti-inflammatory pain medication. The downside of this, of course, is that it can potentially, if you take it long-term, it could potentially lead to GI bleeding, put you at risk of bleeding, put you at risk of developing an ulcer in the stomach. And for patient with diabetes, it can potentially long-term affect the kidney function. So, of course, we always encourage take it when you absolutely need it. Now, acetaminophen, it's basically Tylenol. Many people, including myself and many patients, would tell me, well, Tylenol don't work. It just doesn't work. So I always like to teach patients, I said, when you take Tylenol doesn't work on itself, but when you mix it with when you mix it with something, let's say you take ibuprofen, when you have a headache, you take 2 ibuprofen for headache pain relief. I would tell patient, well, see what happened when you take 2 ibuprofen and add 2 Tylenol to it. So you're taking a total of 4 pills, and that when you mix Tylenol with an NSAID, it actually works a lot better. So a lot of people confuse Tylenol is a form of NSAID, but they actually 2 complete separate class. Tylenol is a medication in itself. All the other stuff, Motrin, naproxen, ibuprofen, Aleve, Advil, you name it, those fall in the NSAID. So they 2 completely different medication. So as an anesthesiologist, we always talk about management of chronic pain using a multimodal analgesic approach. What does that mean? That means we're not trying to use one medication to control pain. We're trying to use multiple different medication and tackle multiple different pathway to manage chronic pain. So other medications, muscle relaxant tends to be quite helpful. Whenever patient have, whether it's neck pain, low back pain, there's always a muscle component there, because every muscle is in the low back or the neck is attached to the spine. So when a patient have chronic neck or low back pain, they tends to do certain ways or adjust, or they try to stand or sit or do certain things to avoid triggering the pain in whether it's the back or the neck, and that can put stress in the muscles. And that will lead to muscle problems. So a lot of time muscle relaxant tends to be quite helpful. Oral steroid, sometimes I prescribed it for people who have an acute flare of their chronic pain, but usually if people on chronic prednisone or chronic steroid therapy is usually prescribed by a rheumatologist, such as people suffering from rheumatoid arthritis. Antidepressant, anticonvulsants, they can be very effective for nerve pain, but again, I don't like oral medication. Why? They tend to cause side effects. So if you think about it, if they work for nerve pain, they're gonna your brain and your spinal cord is a big nerve, and so antidepressant, anticonvulsant, they help with nerve pain by slowing the conduction or the velocity, or you can think of it the velocity of nerve conduction. So that way it slows the brain down. So a lot of people will have side effects like, well, I can't concentrate on a daily basis, it makes me sleepy, makes me tired. That's because they slow the conduction of the nerve down. Herbal medication, there's one medication, herbal medication specifically called turmeric extract. Turmeric is like one of those yellow powder that you can see, you can get it from Costco, you can get it from Vaughn's. It's like, it's a yellow powder that if you have Indian curry before, Indians use turmeric to kind of grind it and make curry out of it. And so there's actually a lot of study that shows that turmeric extract actually reduce inflammation in the body. Many of my patients find it very helpful when they take turmeric on a daily basis. Other medication, for example, magnesium oxide, there's some small studies that shows that it will help to relax the muscle and therefore improve chronic pain. Other things like low-dose naltrexone, ketamine are also effective for specific different type of pain disorder. So that's the pharmacological side, and then now we're gonna get into the final stage, which is the interventional side, which is primarily what I do. Some of the things that we might have heard of: trigger point injection. I would think everybody have at some point heard of epidural steroid injection, or if you know anyone who went through pregnancy, they would always say, hey, I want an epidural. I don't want to experience that pain from delivery of the baby. So that's basically the epidural that we do for people with spinal stenosis, things like that. Other things like facet joint injection, people suffering with arthritic pain. Medial branch block, we'll go into a little more detail later on. Bursa injection. Bursitis is actually quite common source of pain. Sacroiliitic joint injection, again, another common potential source of low back pain. Other things like piriformis muscle injection and spinal cord stimulator as well. So myofascial pain syndrome is probably by far one of the most common source of pain, whether it's in the neck or the low back. Basically, you can think of it as muscular pain. Myofascia is basically referring to fascia pain. Fascia is, think of it like a muscle, and then you have a saran wrap wrapping around the muscle. That saran wrap is the myofascia, and they can become inflamed if you overuse them, you use them inappropriately. For example, myofascial pain in the neck tends to be more common in ladies who are secretary or people who do a lot of desk work, who do a lot of computer work. So they usually come in and complaining they will point to a very specific spot in the neck or in the shoulder that this is the part that hurts them. Usually very sore. They would even sometimes say, you know what, I can even feel like there's a little nodule or a little knot, like a little tight band there. And that's all because the muscle, you overused it, you injured it, it becomes inflamed, and it forms like a little, kind of like a little tight band. They become very tight. They become almost like a little muscle spasm there. A lot of time, muscle relaxant, Voltaren gel, heat would be very helpful. Stretching exercises, physical therapy would be able to help with this pain. Of course, if those don't work, then that's when I kind of step in and consider doing a trigger point injection where I deposit steroid in that location. And also, what we do is when we put the needles into that area, we try to break up the muscle. We try to induce injury to the muscle in that location and therefore facilitate the body to self-heal that problem. Can be quite effective. And of course, then there's another potential source of low back pain and neck pain, and that's mostly related to arthritis. And this is probably by far another one of the most common cause of low back and neck pain. Facet joints, like I said, it been in the earlier, we have joints in the knee, we have joints in the hip, same thing, we have joints in the neck and the low back that allow us to bend forward, bend backward, rotate our neck, things like that. So they can become arthritic as we age because we use it every day, we use it every minute. So you can see the pain. If patient usually come in with low back pain, sometimes they'll say, you know what, some of the pain refer into my butt cheek, they might go into the back of my thigh, but it's really coming from the low back. And same thing with the neck. They would come in and saying, well, I have pain in the left side of the neck. It kind of shoots, it kind of radiate cover into the scapular region or the shoulder area. Sometimes they even have saying that whenever I have this neck pain on the left side, it also causes a headache on the left side. So these are all referral pattern. That's why we always ask the question, like, does it, for neck pain, do you have a headache? If it does have a headache, it does give us an idea. If you can see on the right side, the pattern, the purple pattern that covers part of the head, it's the C2-3 joint. So if the patient come in, I have neck pain, but every time of neck pain, it has headache, so that we know that it's probably the C2-3 joint is involved. It's arthritic. So the referral pattern gives us a pretty good idea of what specific joint are being involved and what we should treat. As you can see on the left side, the picture on the left side, you can see that on the top, there's the normal joint where there's cartilage still in each of the joint that allows good mobility. But as we age, things degenerate, you've been bending your back for 80 years, the joint will be like the cartilage will be wear and tear. So we'll undergo wear and tear and you'll become inflamed like the one in the bottom. So sometimes what we do, we can do a cortisone injection directly into the joint in the back to alleviate the pain. Of course, my experience with that, it's not like the knee, it's not like the hip. Cortisone injection in the back or the neck, they don't necessarily tend to work as well. And also the problem with cortisone injection is that it's very hard to predict. It's quite unpredictable. It could last a week, it could last a month, it could last a year. So that's the problem with cortisone, is that you don't know how long it's gonna last. So of course, someone very smart came up with something called medial branch block and radiofrequency ablation. So the concept is that, yes, we have a joint that's inflamed. We have a joint that's degenerated and it's causing pain. But forget about fixing the joint. We can't reverse that. It's eroded, it's degenerated, we can't reverse it. So instead, what we do is we target the nerve that sends pain signal to that joint. So you can be inflamed all you want, but we're gonna destroy that nerve so you don't have any more pain. So that's actually a very effective way in treating patients with chronic neck or low back pain. And another common cause of low back pain is spinal stenosis. Spinal stenosis, again, it means that you have narrowing in the spine. You can see the picture on the left side. That's when stenosis is when you have impingement, compressing on the spinal cord, and people can develop pain in the low back. They can be shooting down both legs. They can develop numbness and tingling. You can see also on the left side, on the bottom, you can see on the left bottom side, there's the normal disc, and then the right side, there's one of the possible cause of spinal stenosis is when you have a disc protrusion, where the disc leaks out, the content in the disc leaks out, and it actually pushes against the spinal cord or the nerve, and therefore you can develop those symptoms, like I told you, the pain going down the leg. The picture on the right is basically an MRI of the neck. You can see that the MRI picture on the right side is a normal neck or cervical spine, you can see that the black part that's that travels down, it's the spinal cord, and then you can see the white color. The white color is the fluid, and you can see under normal circumstances, the white color, the fluid can pass through the channel without problem. And then you compare it to the one that with suffering from spinal stenosis on the left side. The MRI shows that you don't see the white fluid passing through it. So that means they are so narrow, it's being impinged, the fluid cannot pass through those channels. This is just basically, this is a dermatome showing that people, like I said, a lot of time when we do a pain assessment, we ask, hey, you know, where's your pain and how does it travel? And a lot of time, for example, patient will tell me, oh, well, I have right-sided neck pain and it shoots down all the way to my thumb. And just by asking that question, just by having that patient telling me that, I already know it's probably the C6 nerve being involved. Same thing when you look at the dermatome on the right side. You know, the patient would be telling me, well, you know, my pain is kind of in the low back, kind of shoots down the leg, and it gets to the big toe. And from then on, I know, okay, it's probably an L5 nerve being involved. And so that's why a lot of time we don't really need to do a physical exam, even though, yes, we still do them, but a lot of times just from what the patient tells us, we already know what's going on. And the way to treat it, spinal stenosis or nerve impingement, we do an epidural. Basically, it's just like how we do it for people who are pregnant, they need alleviation for childbirth. We do the same thing, except when we have a pregnant patient, we don't do x-ray because we have a baby there. So we don't want them to expose to radiation. You can see the picture in the middle. That's an x-ray that we use when we perform this procedure. It's a midline approach. We basically numb the patient up in the back, and then we put the needle into that epidural space, and we inject some of the, you can see the black part, that's the contrast dye. It's iodine that shows that, oh, it's an epidural spread, and then we inject the medication there. The picture on the right, it's just a different approach to do an epidural. That one is more specifically near the nerve. So it's a different approach. It's more precise way to actually put the cortisone right next to the nerve instead of the midline approach. Just two different techniques. Another common cause of low back pain, sacroiliitis. Basically, it's a joint that forms between the iliac crest and the sacrum. Usually patient tends to complain about pain at their waistline, like where you put the belt. It can be very debilitating. Pain can sometimes also radiating down into the leg. They can also wrap around into the groin. The picture on the right, it's just an example of how we do steroid injection into the sacroiliac joint. Greater trochanteric bursitis, a very common chronic pain problem that we see in the clinic. Many patients will complain, you know, the side of my hip has been hurting. The most common cause of this pain, and the most common complaint is whenever I sleep on that side, it hurts them. So they can't sleep on that side because you're putting pressure in that bursa. Especially when the bursa is inflamed, they can hurt. So simple things, of course, we always like to recommend starting with physical therapy, some home exercise. Voltaren gel would be helpful, and icing it also can be helpful. But if all those don't work, then we would consider doing a cortisone injection just directly near the bursa, put some steroid, calm the inflammation down. Also very effective in treating using cortisone. Usually bursitis, once you treat it, they don't necessarily come back. But if they do, sometimes we repeat them. Same thing, this is another one that's also very common. Not as common as greater trochanteric bursitis. This is more, probably second most common is ischial bursitis. This is a bursa that's actually, most of the patient will say, they will point to the base of their glute or their butt and basically saying that hurts, usually hurts, especially when they sit, they put pressure on that, it hurts them. Again, we do a cortisone injection that tends to be very effective. Piriformis syndrome, actually I have one patient today that have piriformis syndrome. And basically, patient will complain about pain, specifically they'll point to the area of their butt. And sometimes they may just have pain in the butt, but sometimes they may have pain shooting down the leg. And that's the reason why, if you take a look at the picture on the left, you can see that the piriformis muscle underneath has the sciatic nerve. So imagine if you have a if you have a cut in your finger, the area where you have to cut, it swells up, it's inflamed. So same concept. If your piriformis muscle is injured, it's going to swell up, it's going to be inflamed. When it swells up, well, guess what? You're compressing on the sciatic nerve, and therefore you will develop sciatic pain shooting down the leg. But it's not the nerve that's the problem, it's the muscle that's the problem. So a lot of time, once we treat the muscle, the sciatic pain will go away as well. How do we treat it? Of course, we do, again, most of the time, physical therapy, stretching. If it's a true piriformis muscle, those tend to improve the pain. However, if after you do some physical therapy, stretching exercises, it doesn't seem to alleviate the pain, then we can always do a piriformis muscle injection. Most of the time, patient will improve after a cortisone injection of the piriformis. I have like maybe 2 or 3 patients that it doesn't work, and then something, an alternative treatment would be using Botox for treating piriformis muscle. Botox tends to relax the muscle, and therefore it will help with pain relief. Sympathetic nerve block, radiofrequency ablation, chemical neurolysis. These are some of the techniques that we do. You might have learned this before in biology class about sympathetic nervous system versus the parasympathetic nervous system. So basically we're trying to block those nerves and therefore alleviating pain. These are more specifically for patients who are suffering with visceral pain. Visceral pain, in other words, saying organ pain, organ-related pain, like pancreatitis. Someone have cancer in the stomach. Someone had cancer in the liver. Someone has an inflammatory bowel disorder like ulcerative colitis, or even someone suffering from endometriosis. These injections would be helpful for them. I'm going to go a little bit quicker in these slides. They are just more specific technique. Stellate ganglion block is something that we do for treatment of complex regional pain syndrome for the arms. Celiac plexus block, something that we do for patients suffering from chronic abdominal pain, especially related to either pancreatic cancer or chronic pancreatitis, can be very effective. Lumbar sympathetic, they tend to work sometimes for neuropathy of the legs, as well as mostly it's indicated for complex renal pain syndrome, specifically involving the legs and the feet. Superior hypogastric plexus nerve block is basically a nerve plexus in the base near the pelvic area. And as you can see, it's more indicated for chronic pelvic pain. Female tends to have, younger females, they will have endometriosis. We do these procedures to help alleviate the pain. Or sometimes patient would have cancer in that area, and we do these nerve blocks to alleviate pain as well. Ganglion impart nerve block is more indicated for people who have, for example, a tailbone that they fracture in the past, they develop chronic tailbone pain. A patient with chronic rectal pain that also benefit from this type of injection. The rectal pain could be coming from mostly coming from rectal cancer. Compression fracture, what we do is we do something called kyphoplasty. So again, it's more for elderly patients. Elderly patients tend to develop because we all run into osteopenia and osteoporosis. So whether it's a fall injury causing a compression fracture, or maybe someone could randomly just sleep and wake up one morning and develop acute low back pain, and that's because they develop a compression fracture spontaneously. And once we found that, we can always put in a little, what we call a trocar, or a needle on both sides into the vertebrae, and we can just kind of open a balloon up, open the space, and we put cement inside, and that tends to alleviate the pain almost instantly. We also do some botulinum toxin type 8, basically in short, Botox for chronic migraine headache. These are usually more for patients who have been suffering from chronic migraine for years. They try so many medication, it didn't seem to work, and that's when we do Botox for them. Very effective. The studies show that it's very effective for chronic migraine treatment. The downside is that it only lasts 3 months, so they have to get it once every 3 months. Trigeminal neuralgia is not very common. So I do see that once in a while. Very debilitating facial pain. Again, we do these interventional treatment where we put steroid to calm the inflammation down that's causing this pain, which is related to a specific nerve cell body. And then we get into what we call the more advanced interventional technique for chronic pain management, specifically neuromodulation. As you can tell from the term neuromodulation, you're trying to modulate the nervous system. And what are the two techniques? One is called spinal cord stimulator, and one is called intrathecal drug delivery system. So spinal cord stimulator, it's, to make it simple, make it easy, think of it as a pacemaker in the spine. That's really what it is in a way. FDA approved it for three things. One, failed back surgery syndrome. People who have spinal stenosis in the past, radicular symptom, meaning leg pain, things like that, due to a nerve impingement, they went through surgery, but afterward, they're still suffering from chronic pain. And they see a surgeon said, no, there's really nothing that we can do. You know, there's nothing structurally wrong. Surgery is not going to get you better. They try physical therapy, they try medication, they try some of the injections, nothing seems to help. And that's when we consider spinal cord stimulator for these patients. Complex renal pain syndrome is also FDA approved for this device, and also reticular pain. Again, if the patient is no longer either not a candidate for surgery, or they don't want surgery, or or surgery is just not an option for them, then we would consider spinal cord stimulator. So how does it work? So this is a little cartoon figure of what we believe how spinal cord stimulator work. To be honest, nobody really know or understand how spinal cord stimulator work. It's all based on theory. And the theory is called gated theory. So as you can see in the cartoon, there's the two little train. One says pain, and one, I don't know what it says, but just assume it's like numbness or tingling. So there's the gate guy over there. He's controlling the little, I guess, the lever. So normally only one train can go through the rail and head to the brain. And normally it's the pain signal that can get through the train, get through the rail to head to the brain. So what spinal cord stimulator does is that it turns the gate the other way. So in the old days, when we do spinal cord stimulator, the old school spinal cord stimulator actually causes numbness and tingling in the area where it normally has pain. So what it does is basically it shuts down the pain pathway and open up a different pathway, and therefore help to alleviate pain. If you think about it, the concept is like when you have a paper cut. You know, a lot of time what we do is we put our finger and we kind of rub it, we scratch it, and that will help to alleviate pain. It's not that it's itchy, but we like to, you know, kind of rub it because it helps to alleviate pain. So the concept is the same. By rubbing the finger where you have the paper cut, it seems to alleviate the pain because you're shutting down the pain pathway and you're opening up a different gate. So, but again, it's all theory. Nobody can prove it. But this is what we think the way how this works. This is just a picture of showing how the spinal cord stimulator leads are being placed in the spine. Now, the other device is called intrathecal drug delivery system. I don't do this, but it's basically something that or some of the pain management physician would put in a little catheter into the spinal fluid. And basically what it does is it constantly pumps medication into that area, because the area where it has the most pain receptors is actually in the spine. So by directly injecting the medication there, it will help to alleviate pain. You know, and again, most of the time when we consider neuromodulation is when the patient really ran out of options. There's nothing we can do. We can just try to do things to help manage their symptoms. So in the future, you know, what are some of the rising treatments, some of the things that could potentially come in or to help with that we can consider for chronic pain? So one of the, probably by far the most common is, the most popular is regenerative medicine. You can basically figure out what it is based on the name, regenerative. So we're trying to regenerate things that have been degenerated. Two of the things that you might have heard of: stem cell therapy. The other one is something called platelet-rich plasma. We don't do stem cell therapy, but we do platelet-rich plasma. So basically, the concept behind platelet-rich plasma is that when you have a paper cut, let's say you cut yourself in the finger, it bleeds. The bleeding will gradually stop on its own. And the reason is because the platelets will get to that area and start to basically try to heal up that wound or incision site. So the concept behind regeneration is basically we draw up the blood, we spin it down, we extract the platelets and inject into area that has been degenerated. Because, for example, your knee joint, there's not much blood supply getting into that area. So a lot of time platelets are difficult to reach that area for regeneration. So that's why the concept behind it is to actually extract the platelets and directly inject it into there. Therefore, the platelets can work there and draw the other stuff to come in, fibroblasts, things like that, you name it, to regenerate the cartilage. There are very good studies that shows that actually support this theory. And actually they see that it actually alleviates pain anywhere from 6 months as long as 24 months. Stem cell therapy, on the other hand, has been kind of, the study shows it's kind of mixed. Some study shows that, oh, it works. Some study says it doesn't work. And some say it's 50-50. So at this point, stem cell therapy is kind of hit or miss, I would call it. Also, you also have to understand these are considered experimental. So it's not yet FDA approved. So, if basically it's going to be out of pocket when it comes to, patients who are interested in stem cell therapy or platelet-rich plasma. But I foresee that platelet-rich plasma will eventually, probably within 10 years, it will probably be approved by FDA for treatment, because the results have been very positive. So in summary, chronic pain is very debilitating. It's important to diagnose early, intervene early. Remember the pain cycle. You don't want it to run into a cycle. Opioid is not a solution for chronic pain, as we know about the opioid epidemic. There are a small population of patients who benefit from opioid therapy, but in general, it seems to cause more problems than it will help with chronic pain. Comprehensive multidisciplinary approach is the best way to treat chronic pain or manage chronic pain. And good communication between providers and patients is important. Basically, we try to work with our patient individually to come up with the most customized plan for the patient. And of course, interventional pain therapy should be considered early. Again, we try to intervene the pain cycle by improving the pain. We don't want it to run into the pain cycle where the chronic pain just gradually become worse and worse to the point where it's out of control. I think that's it for my lecture, and we will open up to questions.